Great honor to introduce our guest speaker today, Dr. Zachary NaPier from Roseville, California, from the Sierra Spine Institute. And he's going to talk about something new, and that is simultaneous prone far lateral surgeries, which is an exciting new venture in reconstructing anterior columns. We showed a couple of the intricacies and difficulties. I want to thank our fellows for their case presentations, by the way. I think they're very helpful. I hope you'll find agree. Dr. NaPier comes from Hawaii, and he's done an all-American, very cool educational pathway. Sadly, he did not do a fellowship here, but he attended Dartmouth for his undergrad in math. He went to George Washington University School of Medicine for his MD. He did the Cedars Orthopedic Residency in LA, and he did the Harvard Combined Spine Surgery Fellowship with an all-star cast of faculty. And he's now practicing in California, and he's one of those young guns who's eminently bright and who's opened the doors for new and exciting advances. So we are interested in learning from you about prone position surgery.
All right. Well, thank you for that introduction, Dr. Chapman, and good morning. My name is Zach NaPier. I'm an orthopedic spine surgeon in private practice in Northern California. Seattle Science Foundation has been a valuable educational resource for me throughout my training and in my clinical practice. The quality of content hosted on this platform is truly outstanding, and it is an honor to return here as a presenter. My talk today is titled Prone Transpsoas PTP Lateral Interbody Fusion, Tips and Tricks for Successful Adoption. Dr. Chapman covered my background, listed are my disclosures with relevant relationships bolded. ATEC Spine manufactures many of the implants shown, and the surgical positioners, retractors, and neuromonitoring equipment demonstrated in this talk. Today we will cover a general background on prone transpsoas, followed by a discussion of indications, my experience, technical tips, and as well as case presentations. The advantages of lateral interbody fusion are well documented and broadly fall into two categories: general advantages of minimally invasive interbody fusion and specific advantages of lateral interbody fusion. In general, minimally invasive interbody fusion techniques with relative preservation of the posterior musculo-ligamentous complex will result in less blood loss, faster recovery, and less postoperative pain. Specific benefits of lateral interbody fusion include an optimized fusion environment with a large, mechanically stable graft placed in compression. The size of the lateral interbody cage, as well as its ability to span the dense apophyseal ring, contribute to increased construct stiffness and decreased rates of subsidence. A wide lateral annular release results in substantial indirect decompression of the neural foramen and lateral recess. Traditionally, lateral interbody fusion in the lateral decubitus position provided significant coronal correction and only modest sagittal correction. This led to the development of anterior column release for cases that required greater sagittal correction. Despite over 20 years of refinement, significant challenges exist regarding adoption of lateral interbody fusion in the lateral decubitus position. These include an unfamiliar setup with labor-intensive initial positioning as well as repositioning to the prone position. Although surgeons are certainly able to perform single-position lateral decubitus surgery, this can be logistically cumbersome, compromising accuracy of screw placement and making direct decompression very difficult to perform. Additionally, lordosis is not maximized in the lateral decubitus position compared to the prone position. Other challenges include either direct or traction-related lumbar plexus injury and difficulty with access at L4-5 or more cephalad levels. Prone transpsoas interbody fusion has the following advantages: a single position that is familiar to all spine surgeons. This is an easy setup that generally does not require the surgeon to be in the room. No repositioning is required for direct decompression or other posterior work. The surgeon is able to work simultaneously or alternately on the posterior and anterior aspects of the spine with relative fluidity. We will show some examples where this is useful. Prone position uses gravity to induce greater lordosis than lateral decubitus, Hip extension draws the psoas, and with it the lumbar plexus posteriorly for an increased safe zone anterior to the plexus. And finally, coronal bending improves access to L4-5 in the setting of a high iliac crest, as well as L1-2 underneath the 12th rib. This access is also improved by working through the side of a two-bladed retractor designed specifically for prone lateral surgery. This is an animation demonstrating the coronal bending feature. The patient is strapped into rigid patient positioners, which enable coronal rotation of both the pelvis and the ribs for increased access. These images demonstrate the effect of coronal bending. In the image on the left, before coronal bending, a horizontal line drawn from the left iliac crest intersects the L4 vertebral body. After coronal bending, this line intersects the L4-5 disc space. The pictures on the right demonstrate increased access working outside the retractor. Although an angled inserter is used in the image on the right, it is often not necessary due to the ability of the surgeon to work through the side of the two-bladed retractor. I've included a few relevant articles that I will summarize briefly. This is a study of healthy volunteers positioned in lateral decubitus with table breaking versus prone position with coronal bending. Prone, coronally bent conditions provided better accessibility as measured by the vertical distance between the iliac crest and L5 end plate. All prone positions in this study showed statistically significant lumbar lordosis improvement versus the lateral decubitus position. This MRI study demonstrates that the psoas shifts posteriorly with hip extension and prone positioning. In this cadaveric study, the femoral nerve was marked with radiopaque paint, which demonstrated a larger safe zone at the L4-5 disc space. The nerve was located at approximately the 40-yard line in the lateral decubitus position and the 30-yard line in the prone position. PTP can be used in
Zach, can you go back
Yeah.
one slide?
No problem.
So, so go over that for me one more time. What happens to the femoral nerve?
Yes, so basically, if you look at the L4-5 disc space as a football field, in the lateral decubitus position, it will be in a more anterior station. And so your corridor is going to be anterior to the nerve and behind the vessels. So in the prone position, the nerve will actually move to the 30-yard line, giving us basically 10 more yards of field to play on.
So what happens? So if you're prone, then you're extending your hip,
Yeah, the thought is
and
that
then your
hip
plexus
extension
is moving backwards. Is that what the thought is?
Yeah, the lesser trochanter, the insertion will be pulled posteriorly, and it will bring the psoas with it.
Because I mean, in my experience, you know, the plexus is pretty plastered onto the disc and the plexus. I mean, in the psoas, it's pretty fixed, but it does move a little bit. That's interesting. I don't think I've seen that paper.
Yeah, it's a pretty simple paper, and admittedly, there are only 7 cadavers, but it's nice because it's just a pretty clear takeaway. And then we'll talk a little bit more experientially how that may be borne out, but you know, certainly not level 1 evidence. So PTP can be used in the following clinical scenarios and many more. It's become my workhorse for degenerative pathology in the lumbar spine. In terms of my experience, as of February 2023, I've performed 65 Prone Transpsoas cases, totaling 109 levels. 57% of these cases involved L4-5. I've also performed 4 cases and 7 levels of retropleural prone lateral fusion. I've had no vascular or bowel injury, no reoperation for hardware malposition, no motor deficit at 6 weeks post-op. In terms of complications, I've had 3 inadvertent ALL ruptures recognized intraoperatively and treated with plate fixation, and 1 air leak with the intraoperative chest tube placement. In regard to technique, the same basic principles of lateral surgery must be respected, whether you're in the prone or the lateral decubitus position. The main steps are developing the retroperitoneal space, mapping and traversing the lumbar plexus, limiting retraction injury, using good carpentry with respect to discectomy and end plate preparation, and appropriate implant selection and placement. I will provide a brief overview of my technique. I was very fortunate to learn this operation from accomplished lateral surgeons and pioneers in the field, including my practice partner, Tyler Smith, and others. I've incorporated their techniques as well as many of my own in a way that works well for me. The prone position is familiar and it maximizes lordosis, but the major drawback is that gravity is no longer bracing your patient's side against the table, and it is no longer keeping your shim embedded in the disc space. There will be a tendency for the patient to recoil or bounce and for your shim to piston out of the disc space, especially with percussive maneuvers of trialing and implant insertion. The key to positioning is to minimize recoil or bounce of the patient. I achieve this by firmly fixing the patient into the positioners, so when I am doing trialing and percussive work, the patient does not piston away from me. These positioners are specifically designed for prone transpsoas cases and provide excellent stability. Retroperitoneal access is the first critical step of this operation. In the prone position, abdominal girth tends to pancake outward and results in longer retractor lengths than lateral decubitus. Traversing this length blindly can be intimidating, especially early in the learning curve. To convince myself that no viscera or abdominal contents are interposed, I use a technique of direct palpation of known landmarks all the way to the spine. I typically use my percutaneous screw incision as an accessory, but you can also use an open midline incision or a dedicated accessory incision. Once you're comfortable, no accessory incision is necessary, but the accessory incision is an excellent way to ensure safe access. I will describe this access technique in greater detail, utilizing the percutaneous screw incision as an accessory. The first step is to make your perc screw incision and palpate your pedicle screw start site. Then move laterally toward the tip of the transverse process and enter the retroperitoneal space. You should be able to feel the surface of the psoas medially. Next, make your lateral incision and dissect through the abdominal wall, popping through the transversalis fascia. Clearly demarcate the retroperitoneal space by palpating the inner table of the ilium and the undersurface of the 12th rib. I will make my fingers touch to convince myself that there is a clear pathway from my incision to the psoas. In this image, the finger in the lateral incision can reach the spine, but usually this is not the case. Often, especially early in the learning curve, you will feel material interposed between your fingers.
So Zach, you do this on lateral and prone?
Not on lateral, I don't do an accessory.
Okay, because I mean, we used to do this when we first started doing it.
Yeah.
But most people don't do it anymore. I don't know. Do you do it for prone?
I do not do it for lateral.
Got
I
it.
do it for prone.
Oh, you do it for prone?
Yeah, because it's a longer distance, and very, very rarely am I only making a lateral incision. So I'll have either a perc screw incision that's convenient, or if I'm doing midline work, that works as well.
Mm-hmm.
And because it's a longer working distance, and when you feel tissue between your fingertips, and you're pretty sure that it's not bowel, you have to be totally sure. So I use the accessory. It's easy to use. You don't have to, but it's probably more relevant in a prone position. So at that point, the retroperitoneal access has been established. I will enter the retroperitoneal space through my percutaneous incision, again, to ensure there's no interposed materials. I'll place the dilator now on the known surface of the psoas and advance to the surface of the disc space. So this is a cadaveric demonstration of my retroperitoneal access technique. We start by making the percutaneous pedicle screw incision, bluntly developing the intramuscular plane. I then move my finger laterally, advancing into the retroperitoneal space. I make my lateral incision directly over the disc space of interest and dissect subcutaneous tissues, followed by the layers of the abdominal wall. Often, I can advance my finger directly through the transversalis but for patients with more robust tissue, I will take the tip of a Metzenbaum scissor. Once loss of resistance is encountered, I open the Mets to further develop my opening. Then I develop the peritoneal space by touching my fingertips. I use a windshield wiper technique to palpate the inner table of the ilium as well as the 12th rib, making an effort to push the peritoneum anteriorly. I can also directly palpate the psoas with my left finger, which I will use to escort my dilator to the psoas. I protect the tip of my dilator with my right index finger and shepherd the dilator to my left index finger and place it on the surface of the psoas. I typically aim for the anterior 1/3, 2/3 junction of the vertebral body. After mapping the plexus and dilating in the standard fashion, I prefer to use a rigid two-bladed retractor designed specifically for the prone position, which has several advantages over a conventional three-bladed retractor typically used in the lateral decubitus position. The two-bladed retractor is inherently more rigid than a three-bladed retractor and allows for placement of an anterior and a posterior shim, which provides significantly more retractor stability than a single posterior shim. This is especially important in the prone position since gravity is no longer keeping your shim anchored in the disc space, and there is a tendency for the shim to piston out and the retractor to drift anteriorly toward the vessels. The two-bladed retractor also allows me to dock anteriorly, which I will do about 90% of the time. This allows me to keep a greater distance from the plexus, and most of the time at L4-5, I will have triggered EMG values greater than 12 in all four quadrants. After placing my anterior shim, I'll open the retractor just barely enough to pass 18 millimeter instruments. This minimizes retraction of the psoas and the plexus. I will then place a posterior shim, which establishes an extremely well-fixed and demarcated channel for discectomy. Given the tendency of the retractor to drift anteriorly in the prone position, it is especially comforting to have a firmly anchored anterior shim, providing a clear boundary between the operative field and the vessels anteriorly. By contrast, a three-bladed retractor only allows for placement of one posterior shim and requires the use of an ALL retractor to establish a boundary between the operative field and the vessels. In the picture on the bottom left, I've placed an anterior shim, and in the picture on the middle, I've established an operative corridor that is just large enough to allow passing of the 18 millimeter instrument. The picture on the bottom right shows an appropriately sized operative corridor, which is just big enough to fit the 18 millimeter trial with rigid fixation provided by anterior and posterior shims. I will also be monitoring saphenous SSEP throughout the case to detect stretch injury. As the saphenous is a terminal branch of the femoral nerve, it may serve as a canary in the coal mine for impending plexus injury. Once I like my position on the surface of the psoas, I will advance my dilator through the psoas onto the disc space and confirm my position with fluoroscopy. I'll then advance my guide wire, anchoring the dilator in place. Directional triggered EMG allows me to map the plexus and establish a safe anterior corridor to the disc space. Low EMG readings indicate close proximity to the plexus. I prefer high numbers in every direction, indicating that I am far from nerves, but I'm fine with low numbers in the posterior direction, indicating that I am anterior to the plexus. If I have low numbers both anteriorly and posteriorly, this is not acceptable, as I am in an axilla and I must start over with a more anterior start site or more anterior to posterior trajectory through the psoas. I also use this opportunity to measure my retractor length and make sure I feel the surface of the disc with each dilator. Next is retractor insertion. This is a rigid two-blade retractor with independent blade motion and various visual indicators to confirm orthogonality in multiple planes. I open the retractor slightly and remove my dilators to obtain a lateral X-ray to confirm appropriate position. I then stimulate my proposed shim insertion site, insert the shim to the surface of the disc space, and switch to AP fluoroscopy to confirm trajectory. I will also raise the table to eye level to maintain orthogonality. Once my anterior shim is inserted, I want to establish my operative field as small as possible while being able to pass 18mm instruments. I will use an 18mm trowel to ensure smooth passage without an excessively large field. I will then stimulate my proposed posterior shim insertion site before placing the posterior shim on AP fluoroscopy. When the shims are perfectly superimposed, we can be confident that stable disc access has been achieved and we are ready to start the discectomy. The discectomy becomes very simple once two shims have been placed, establishing a rigid orthogonal operative corridor. Once discectomy is completed, I typically take a shot with my trowel and decide whether to remove the anterior or posterior shim before placing a 22mm implant. In this case, on the bottom left, there's a well-placed 18mm trowel, and I elected to remove the posterior shim and place a 22mm implant.
5 minutes? Can you do 5 minutes?
Probably like 10.
How much time do you need?
Probably 10 minutes from now, 10 or 15. Yeah. Okay. The discectomy starts with an annulotomy knife, followed by the passage of a small Cobb elevator to separate any remaining cartilaginous end plate. I'll go through we're running a little short on time, so I may just abridge the discectomy portion. It's fairly standard technique, using a box cutter, removing the discectomy and placing our cage. So these clips were taken from a more complete technique video that is available online. With the remaining time, I'd like to share some cases. That's good. Probably about 5 to 10 minutes of these. Yep. So first case, this is an 84-year-old male with persistent lower back pain and radicular pain and weakness after an L4-5 laminectomy and posterior spinal fusion at an outside hospital. Imaging demonstrated adjacent segment degeneration at L3-4 with foraminal stenosis, as well as a pseudarthrosis at L4-5. I placed the patient in the prone position, made bilateral Wiltse incisions to remove his rods. I then did PTP laterals at L4-5 and L3-4 before placing percutaneous pedicle screws bilaterally. We had minimal blood loss, less than 2 hours of total operative time, and the patient was ambulating within hours of surgery. In this case, I was able to use a simultaneous posterior and lateral workflow and avoid working through a revision laminectomy bed. The next case, and this is pretty similar to our first case this morning, it's a very active 59-year-old CrossFit enthusiast mother of 7 who was referred to me by her physical therapist. She had lower back, radicular pain, and quad weakness with imaging demonstrating L4-5 anterolisthesis. In her case, there was about 15 millimeters of bony overlap, and the smallest lateral cage is 18 millimeters. So I used a screws first reduction technique. So in the prone position, I placed my perc screws. I did a provisional reduction with reduction towers, which allowed me enough overlap to place my interbody cage. Then I completed the reduction, and there are the final x-rays. She's about 1 year out now, and she's doing great. And so I think if you can pull this off, that's the best way, in my opinion, to approach the clinical scenario that you described. But there are factors that you must consider, anatomical factors, including overlap of vertebra as well as plexus and vascular anatomy. This is a great case to illustrate indirect decompression. In the image in the upper left, you can see the inferior articular process of L4 in the lateral recess, completely reduced postoperatively. Next case is a 63-year-old railroad mechanic, lower back and radicular pain and quad weakness. Unfortunately, our MRI cuts were not aligned with the disc space. I find the multiplanar CT reconstruction very helpful to delineate the psoas and vascular anatomy. In this case, there's an anterior station psoas, and this is what we would describe as our Mickey Mouse anatomy. This has been a relative contraindication to lateral interbody fusion. In this case, I consented the patient for prone lateral with the TLIF equipment on backup. So initially, I tried to approach and was getting 2 millimeters in all directions without a safe anterior corridor. I used a technique of rotating the patient away from me by 30 degrees, which allowed me a more anterior access channel. And I was able to place my interbody in a standard fashion and reduce the spondylolisthesis. So the next case, this is an adjacent segment case. A 70-year-old heavy equipment operator with severe lower back pain, postural fatigue, and leg weakness. He had a history of an L2 to 5 TLIF in 2009. Imaging demonstrated a focal thoracolumbar kyphosis of 34 degrees from T11 to L2 with a misplaced screw at L4-5. I approached this case in a staged fashion. First, I placed a hyperlordotic ALIF at L5-S1, followed by 3 15-degree lateral cages through a prone retropleural approach. By resecting a 6 centimeter fragment of rib, I was able to clearly approach 3 disc spaces. Couldn't find a dedicated illustration for this approach in the literature, so I borrowed and rotated this one from Dr. Uribe, who's done significant work in defining and describing lateral thoracic and thoracolumbar junctional anatomy. This is the same view of my operative corridor, with the only difference being a rigid two-bladed retractor described earlier. On the second stage, I did a T4 to pelvis. Maybe I could have stopped in lower thoracic, but his PI was borderline, and I thought the PJK risk was too high, especially with the amount of junctional kyphosis he had. This is an example of using PTP and hyperlordotic ALIF to achieve sagittal correction and fusion through the anterior column. He's now 1 year out with improvement in his sagittal profile. Next patient is a 63-year-old who presented with lower back radicular pain, postural fatigue, and foot drop. She had a degenerative scoliosis, osteopenia, a relatively low pelvic incidence. I started with a 4-level PTP. As you can see in the images, the coronal bending feature of the patient positioner provided an excellent provisional reduction of the scoliosis. For this cage, I used 10-degree implants rather than my preferred 15 because I didn't trust her bone and the sagittal balance wasn't bad. I finished with a lower thoracic to pelvis instrumentation and fusion with no direct decompression other than a TLIF at L5-S1 for stability. She's now 4 months out with improvement in her preoperative symptoms. Last but not least, one of my own complications. This is an 87-year-old woman who presented with pseudarthrosis after I did an L4-5 laminectomy and posterior spinal fusion for spondylolisthesis 1 year prior. The MRI demonstrated a narrow corridor anterior to the plexus. I was able to work simultaneously, first opening her posterior incision and removing the rod, then placing a PTP interbody before replacing the rods. Surgery took less than an hour with immediate symptomatic improvement. She went home the next day, and now she's 4 months out with no complaints other than, why didn't I do that surgery the first time?
Nice.
So when do I not use PTP? Anytime the patient needs direct anterior canal decompression, or I feel like I need improved anterior visualization, such as an ACR or corpectomy. Some of this has to do with 2 versus 3 bladed retractor design, and this may change soon with retractor innovation. This is a summary slide comparing lateral decubitus and prone techniques. In terms of setup, direct posterior work, and canal decompression, the advantage clearly goes to prone. Lateral has the advantage for direct anterior canal decompression. Simultaneous or alternate posterior work is easily performed in the prone position. The prone position results in more lordosis than lateral, and neural complications and access may be better. There are many exciting research projects ongoing that will help us to more clearly delineate the role of each technique in order to best serve our patients. In conclusion, traditional lateral decubitus and PTP are both very good techniques. Rather than think of these operations as rivals, I think of them as a complementary tool set. In many ways, PTP is a natural evolution of lateral interbody fusion. It has become my workhorse approach for degenerative lumbar pathology, and there are exciting applications forthcoming for more complex surgery. Thank you.
Nice job, Zach. Thank you.
Yeah.
So my first question to you is, if you can go back to one of those lumbar plexus shots. So you showed very nice videos, how you navigate and use neuromonitoring, live neuromonitoring that you observe as to where the plexus is. And again, I got to credit my partner, Dr. Oskouian. I sent him a lot of far lateral approach patients. And he's had, I think, 2 patients over the 8-9 years we've worked together where he canceled the far lateral interbodies because he said, I cannot find a safe corridor. How often has this happened in your case?
Yeah, that's happened to me one time, and that was on an extreme Mickey Mouse where I didn't think it was going to work, and I told that to the patient, and she still consented for me to try. And so that's the only time it's happened to me. Granted, I don't have Dr. Oskouian's experience, but I think there is something about the prone position that makes it safer and the corridor a little more accessible. And there are techniques and maneuvers you can use to essentially sneak in front of the psoas from a prone position.
I want to not hog the microphone. Do you want to go ahead?
I mean, I think this is, I think you did a great job presenting, Zach. I think, I agree with you. I think, when you go to, we just had our advanced lateral course recently, and there's a lot of debate, and some people on the lateral, versus prone lateral camps, and I think they're complementary. I think it's a natural evolution of the procedure, and I'm excited. I think just that whole area. I remember when I started doing lateral, there wasn't even codes or interbody, devices, neuromonitoring. All that stuff is really, it's evolved, and I'm excited. I think there's a lot to learn, and there's a lot of scientific as well as clinical data to be collected. So great job on presenting.
I'll pass the microphone on to our Tacoma colleagues. So you're experienced practitioners. Sorry, I have to excuse myself in a second. Are you comfortable doing this now? What would it take for you to kind of make that jump to a prone position surgery?
A course at least, and doing a couple cases with somebody who's got some experience. Currently, I'm not doing any, but it's intriguing. I like this concept better than lateral decubitus, so definitely interested.
I'm convinced. Are you going to do prone OLIF procedures? I don't want to say a company's name here.
I do think there seem to be some advantages to doing it in the prone position. I have not done that in my own OR yet. I have evaluated some of the retractors and positioning equipment and implants that make that more or make that possible. I've already said I really am a believer in a percutaneous lateral approach, however that's done. So I certainly think that's been transformative. And the last comment I wanted to make, since we still do have a few of the fellows here, is I'd applaud your radiographs, the radiographic results you're getting, and I think as we evolve as a specialty into more limited access type approaches, which I think we all recognize is where things are headed, it's important that we continue to sort of adhere to the principles of spine surgery. And I try to make sure that every fellow has those memorized by the time they finish their time here. But I won't call anybody out today, but to repeat, those are the biology of bone fusion, the anatomy of decompression, neural decompression, the anatomy of spinal alignment, and the biomechanics of fixation. And particularly the case you showed with the deformity, that you got a very nice result with respect to the alignment and with the extent of the fixation. And certainly we see cases that fail because their practitioner has kind of taken technique over these fundamental principles. And I'll stop with that. And other than that, I have no strong opinion.
Yeah, can I just reply to Dr. Hart? Thank you for mentioning that, and I couldn't agree with you more. Don't do MIS just because you think it's cool or you want to make a small incision or operate on someone in a surgery center. That's the wrong reasons to do it. You want to do it because you're preserving soft tissues, and if you're able to achieve just as good or better sagittal results, better decompression results, better stabilization results, then do it. Don't do an inferior surgery just because it's quote MIS. And that's a principle I always keep in my mind when doing these cases.
Yeah, we have an acronym for what Dr. Hart's describing here. As orthopedic surgeons, we're all familiar with the term ORIF, open reduction internal fixation. And with MIS, we see a lot of OIF, open internal fixation.
Don't OIF the spine.
The reduction part was omitted. So in the reductionist approach of MIS, it's become OIF. And that's a rich field of, unfortunately, revision surgery. So, but thank you. This is a very nicely illustrated and nice case selection based presentation. So thanks for sharing it. Thanks for coming up. Great to have you here. A lot of fun.
Thank you. Really appreciate it, guys.
Great job, Zach.
Thank you.